On. So in the last slide, we were talking about fluid and electrolyte imbalances that affect water levels, sodium, chloride levels, and then we sort of categorize them in terms of tonicity. Also important are potassium levels, right? And actually, potassium levels are incredibly important. So potassium levels are actually incredibly important, and if you haven't already sort of navigated those NCLEX type questions, if there is a question that's asking about a potassium alteration, that's an emergency, right? Especially, so hyperkalemia, hypokalemia, incredibly important electrolyte imbalances that can often be very life-threatening. Okay? So potassium levels are also very important in terms of maintaining cell function. Sodium and potassium levels are both, when they become altered, their main effects are in cell excitability. Okay? So when sodium levels rise, what effect do you think that has on cell excitability? So you're increasing the concentration gradient for sodium. What do you think that does to cell excitability? So you are increasing the concentration gradient. That's all right. You're increasing the concentration gradient, which increases the driving force for sodium to get into the cell. What effect is that going to have on excitability? It increases excitability. Elevated sodium increases excitability, and decreased sodium decreases excitability. And so when it comes to sodium alterations, some of the earliest manifestations have to do, or some of the earliest life-threatening manifestations has to do with brain function. So you can get irritability or lethargy depending on what's going on. And the worst case scenario you can have seizure. Okay? So potassium levels also affect cell excitability. When extracellular potassium levels go up, what do you think that does to excitability? When extracellular potassium levels go up, I have no chalk. It will actually increase excitability of the cell. So if you think about this, potassium, what is the normal direction of potassium flow? Out. Okay? If you increase extracellular potassium, are you promoting potassium to leave the cell, or are you increasing? Are you decreasing the likelihood that it's going to leave the cell? You will decrease the likelihood it will leave the cell. And when potassium stays in the cell, it's a positively charged ion within the cell. And that depolarizes and causes excitability. Does that make sense? Absolutely. You elevate extracellular potassium, you are actually decreasing the driving force for potassium to leave the cell. Okay? And when you do that, potassium is more likely to stay inside the cell and contribute a positive charge to the interior environment, okay, which will excite the cell. So hyperkalemic conditions actually increase excitability, and hypokalemic extracellular fluid. When we talk about hypo and hyper, we're always referring to extracellular fluid. Okay? So hyperkalemic conditions cause increased excitability. Hypokalemic conditions cause decreased excitability. And the major life-threatening effect is in cardiac function. Okay? So alterations in potassium levels will actually cause arrhythmia and EKG abnormalities, whether potassium is high or low, and there's different sort of patterns to that, and you'll read about that. But in the worst case scenario, it can cause cardiac arrest. Okay. Now, don't be confused when you read, well, you will be confused, but that's okay. When you go and read that section on fluid and electrolyte imbalances, and when you read that one of the signs of both hyper and hypokalemia is muscle weakness. Okay? That's true. Both ends of the spectrum you get muscle weakness, but you get muscle weakness for different reasons. Okay? On the one side, when cell excitability is very high, you get muscle weakness because of sort of tetany, right? Overexcitability of the muscles. And you get muscle weakness on the low end of potassium because of decreased excitability of the cells. So that's an example of how just knowing how it affects one cell does not necessarily tell you how it will affect the entire system. Yes, ma'am?
How does the change in gradient if you have an increase in potassium outside of the cell affect the potassium solution during the action potential? Is it significant?
How it will affect the movement and the action potential. It depends on how high potassium levels are or how low potassium levels are. If they are high enough, they can affect the production of an action potential at all. Okay? If the potassium levels are high enough, it can affect the membrane potential, and it can end up causing the membrane potential to be so depolarized that you fire an action potential, but then you never get to that refractory period. And it affects your ability to produce subsequent action potentials. Okay?
So if it doesn't come back down, does it continuously
depolarize? No, it's not a continuous action potential because, exactly. You get a change in membrane potential that doesn't allow you to reestablish the concentration gradients and fire another action potential. Okay? So, like I said, the effects on the system can be kind of complex, and it depends on a lot of factors. So, read through those manifestations and focus your attention on what is most common and what is most life-threatening. Okay? As you answer those questions and read through that section of the reading. So in terms of potassium balance, potassium levels are regulated, like I said before. They're regulated systemically by the renin-angiotensin system, and they're regulated intracellularly through the sodium and potassium ATPase pumps. Okay? However, there are certain conditions that actually can cause changes in extracellular potassium levels that have really nothing to do with either the pumps or the renin-angiotensin system. Okay? So when potassium levels in extracellular fluid are high or low, it may reflect high total body potassium or low total body potassium. Okay? But it may also reflect no change in total body potassium, but a shifting of potassium between ICF and ECF. Okay? So there are certain conditions that create the situation of hyperkalemia or hypokalemia, but what's really happening is that sodium is just shifting from inside to outside or outside to inside. Okay? And so some of the situations where this happens is in states of altered pH. Okay? And when we measure pH, we're measuring the concentration of what in the fluid? Positively charged hydrogen ions. Okay? And so when the pH of a solution is more acidic, we have more positively charged hydrogen ions. Okay? And so what happens is when ECF hydrogen ion concentration goes up, that translates to elevated intracellular hydrogen ion concentration. Okay? Now the cell always has a mechanism when things like this happen to maintain electroneutrality. Okay? If it's going to accumulate positively charged hydrogen ions, it's got to swap out, it's got to get rid of some other positively charged ion. And the ion it gets rid of is potassium. Okay? So as hydrogen ion concentration accumulates in the cell shifts potassium out to maintain the same membrane potential. And so in that case, what is that going to appear as? It's going to appear as hyperkalemia. Okay. So in acidotic states, you get the shifting of potassium out of the cell and this apparent hyperkalemia. Okay. And the opposite happens with alkalosis. In alkalotic states, you get a drop in hydrogen ion, positively charged hydrogen ion concentrations. Okay. And as the H+ levels inside the cell go down, the cell maintains electroneutrality by shifting potassium inside. Okay? And that's going to appear as a hypokalemia. But in either case, correcting the pH imbalance corrects the potassium imbalance. Okay? So that's something to keep in mind. When somebody's in an acidotic state, you can expect them to have slightly elevated potassium levels. When they are in an alkalotic state, you can expect them to have low potassium levels. Another factor that affects potassium shifting, intracellular, extracellular shifting, is the availability of insulin. Okay. Insulin's function is to allow for the entry of glucose into cells that use glucose. Okay? So insulin allows glucose to enter cells. Now glucose, when it enters cells, it could be used as energy or it can be stored in the form of glycogen. In order to store glucose as glycogen, that process, the production of glycogen, requires potassium. So when insulin acts on insulin-sensitive cells, it causes the entry of both glucose and potassium at the same time. Okay? So insulin binds to its insulin receptor. It stimulates the entry of glucose into the cell. It also stimulates the entry of potassium into the cell. And so then now this glucose, in the presence of high potassium, can form glycogen. Okay. So that means that if someone is, let's say, lacking insulin, let's say they have type 1 diabetes and their pancreas is no longer producing insulin, okay, they're going to have a lot of problems. But one of the problems is also that their potassium levels are going to appear elevated because they don't have sort of the normal baseline level of insulin promoting that baseline level of potassium entry into the cell. Make sense? Yes, sir. Potassium shifts with hypothermia. Potentially, I'm not familiar with that, but potentially. Okay. So, insulin deficiency, you may end up with elevated potassium levels. And on the flip side, let's say this person's not diabetic. Okay, this person is not diabetic. But they do have potassium levels they're hyperkalemic, and they have potassium levels that are dangerously high. Okay? For whatever the cause is, potassium levels that are dangerously high, but they're not diabetic. An emergency treatment for acutely severe hyperkalemia is often the administration of insulin, okay, in order to bring those potassium levels down. And if you only gave insulin, what's the next problem you would have in that patient? You would have hypoglycemia if you only gave insulin to a non-diabetic person. So what's often done is you give insulin and glucose at the same time. Usually it's in 5 DW, right? Just dextrose water, so that you can get this rapid shifting of potassium in the cell without causing hypoglycemia. Right? Because insulin is going to bring not just potassium in the cell, but also glucose. That makes sense? So insulin levels, a person's insulin levels will affect their potassium levels, and also emergency treatment of extreme hyperkalemia is often insulin in dextrose water, just to bring that down, to bring them away from the danger zone of cardiac arrest. Okay? It's not obviously dealing with what's causing the hyperkalemia, but it is an emergency treatment. And then catecholamines, circulating catecholamines. What are our catecholamines? At least that was a good summer break. Our catecholamines are norepinephrine and epinephrine, right? It's our sympathetic neurotransmitter, norepinephrine, and hormone, epinephrine. When these catecholamines bind to different receptors, they create a potassium shift in that cell, or whatever cell that it's binding to that receptor. Beta-2 adrenergic receptors causes potassium to move into the cell, and alpha-2 adrenergic receptors stimulates potassium to move out of the cell. Okay? Which isn't necessarily going to make a significant effect on total body potassium unless you have really intense stimulation of your catecholamine system, really intense stimulation of the sympathetic system. But generally, what's more important in terms of what affects potassium balance is your pH state and your insulin levels. Okay? And so when we'll talk about diabetes later, but some individuals who have uncontrolled type 1 diabetes, where their insulin levels are just, they're bottomed out. Okay? Insulin levels are bottomed out. Glucose levels are through the roof. Their body can't get at the glucose for energy. And instead, they start burning stored fat. And anybody who's ever experimented with the Atkins diet knows when you are trying to burn your stored fat, okay, that it puts you in a state of what? Ketosis, right? Where you are burning stored fat and you're producing keto acids, you're producing ketones, and it gives you this sort of sweet acetone breath. And this complication in diabetics is called diabetic ketoacidosis. Okay? So they don't have any insulin. They're acidotic because of a buildup of keto acids. Okay? What's happening to their potassium in that case? Extremely high, right? Their potassium levels may be extremely high because they don't have insulin bringing the potassium inside the cell, and they're acidotic, creating this potassium shift. Okay? And so at first examination, their potassium levels might be very, very high. So this is a patient that you might want to get on an EKG before you do almost anything else to make sure that they're not throwing some life-threatening arrhythmias. Okay? So understanding how these factors affect potassium levels is really very, very important, because potassium alterations can be very, very life-threatening, can be serious emergency. Okay. Okay, so acid-base balance. In order to maintain cell function, you have to maintain adequate acid-base balance. Right? The pH of our extracellular fluid, which will determine the pH of our intracellular fluid, needs to be maintained at the healthy range, right? And the healthy range is somewhere between 7.35 and 7.45, somewhere in that basic range. Not basic as in alkaline, but general range. Now, the way that we maintain acid-base balance is by having a variety of what we call buffer systems in our extracellular fluid. And a buffer system, okay, does exactly that. It buffers changes in pH. Okay? So a buffer system, if you introduce an acid into that solution, a buffer will absorb the acid to prevent a change in the acidity, or excuse me, of the pH of the solution. Okay? Or if you introduce a base into the solution, the buffer should be able to absorb that base in order to maintain the pH of the solution. That's what buffers do. Okay? And buffers, all buffers are substances that can be present in both a weak acid and a weak base form. Okay? So they have some form that they can basically either absorb or donate a hydrogen ion in order to buffer that solution. Okay? And we don't just have one buffer system in our extracellular fluid. We actually have several buffer systems rather. Phosphate, which is all over the place, right? Phosphate can be present in either HPO4 minus 2 or H2PO4 minus 1, right? Meaning it can either absorb or donate a hydrogen ion as needed, right? That's what a buffer system is. Proteins, all proteins actually, every protein we have can absorb or donate hydrogen ions, both intracellularly and extracellularly. Hemoglobin can even absorb or donate a hydrogen ion. And then most important buffer system we have is a bicarbonate carbonic acid system, okay, which can also donate or absorb a hydrogen ion. Now, all of these different buffer systems, they tend to operate at different pH ranges. Okay? So they tend to have different operating ranges so that overall they overlap so that you have a much wider operating range, right? Buffering range. Okay? So the bicarbonate system is our most important buffer system in our body. These other ones are contributing in important ways, but our bicarbonate system is really our most important buffering system. Okay. And so bicarbonate and carbonic acid come from CO2. Right? Bicarbonate and carbonic acid come from CO2. And where does CO2 come from? Metabolism, right? CO2 is coming from aerobic metabolism, right? It's a very good summer break. So CO2 is coming from, I'm glad to see that, warms my heart. CO2 is coming from metabolic production, right? And then we are getting rid of some of that through exhalation, but we keep quite a lot of CO2, right? And the CO2 that we keep in our bloodstream, some of it is dissolved in our plasma. And what measure of our blood measures the amount of CO2 that's physically dissolved? Our PCO2, right? The partial pressure of CO2. But the rest of that CO2, some of it is physically dissolved, some of it's bound to hemoglobin, and then the rest of it gets converted to carbonic acid and bicarbonate. Okay? And of course, that process of taking CO2 in the plasma and in the presence of water, right, this process has to happen within a cell because it requires that carbonic anhydrase enzyme. Right? It requires that enzyme. But it will form carbonic acid, and then carbonic acid can dissociate and form free hydrogen ions and bicarbonate. Okay? And this ability for carbonic acid to be present either in this form or in this form and go back and forth is what makes it a buffer. It can either donate a hydrogen ion or it can absorb a hydrogen ion, okay, depending on what's going on in the solution. Now, the regulation of the production of carbonic acid, okay, the regulation of this buffering system is done by controlling the levels of CO2 and controlling the levels of bicarbonate and hydrogen ions. Okay? So this buffering system can be controlled by either controlling the levels of CO2 or controlling the levels of bicarbonate or hydrogen ions. So we control CO2 by controlling our respiratory rate. When our respiratory rate goes up, what happens to PCO2? Goes down. When our respiratory rate goes up, we blow off more CO2. CO2 goes down. Okay? When CO2 goes down, carbonic acid levels go down, and it is a way of getting rid of acid. Everybody agree? Now, bicarbonate levels and hydrogen ion levels are regulated by the kidneys. The kidneys control the rate of bicarbonate reabsorption, right, meaning retention, and the rate of hydrogen ion secretion, which is elimination. Okay? When we secrete hydrogen ions, we're getting rid of acid. When we retain hydrogen ions, we're trying to hold on to acid. When we reabsorb bicarbonate, we're retaining base. Right? When we don't reabsorb bicarbonate, we're getting rid of base. Okay? And so this is how our bloodstream or our bodies can regulate this buffer system in order to compensate for any problems in pH. But there's very different time scales on these two sides of the reaction. Changing CO2 levels is a very rapid compensation, right? It's on the order of minutes to hours. Okay? You can change your respiratory rate and change your CO2 very quickly. But changing bicarbonate reabsorption and hydrogen secretion regulated by the kidneys is a much slower effect. We're talking about hours to days. It's very effective, but it's much slower. Okay. So if someone is acidotic, and I'm not telling you the cause, but if someone is acidotic, what direction are they going to try to push their CO2 levels? Down. That make sense? And what direction would they push their bicarbonate levels? Up. And their hydrogen ion levels? Down. Okay? So that's going to be sort of the rationale for what direction these things are going to go and how the body responds. So acid-base disturbances have a cause, and then they usually have a compensation. Okay? Acid-base disturbances have a cause, and they have a compensation. The causes for acid-base imbalances come in two categories. Two general categories: respiratory and metabolic. Okay? And I know that none of this is new to you. So if someone's in acidosis, they could be in respiratory acidosis or they can be in metabolic acidosis. When someone is in respiratory acidosis, okay, the respiratory system is the cause of the acidosis. Okay? Which means automatically it's not going to be part of the compensation. Make sense? The respiratory acidosis means the respiratory system is the cause, and so it's not going to be part of the compensation. So what will cause a respiratory acidosis? Hypoventilation. Something happens and someone is not breathing enough. They're under-breathing. That's one cause. Under-breathing means they are not blowing off CO2, and what parameter in their blood is going up? PCO2 will go up, which is causing the acidosis. Okay? So hypoventilation, problems with gas exchange, right? If you've got damage to the site of gas exchange, even if someone is trying to breathe, you don't have movement of CO2 out of the body and you have CO2 accumulation. That's a respiratory acidosis. Respiratory alkalosis, what's a reason why somebody would be in respiratory alkalosis? Hyperventilation. You're blowing off too much CO2. Okay? You're blowing off too much CO2. Now, so that's actually pretty straightforward. A respiratory acidosis means an accumulation of CO2 because you're not blowing it off. And respiratory alkalosis, you're blowing off too much. Okay? Both of these will be compensated by the metabolic system. So the kidneys are going to try to compensate for this problem. And that's going to be a difficult thing because the kidneys don't operate. The kidneys can't have an effect on blood pH as quickly as the respiratory system can. Okay? But given enough time, the metabolic system will try to compensate. It's a little less straightforward why you would have a metabolic acidosis or metabolic alkalosis. And really, metabolic acidosis and alkalosis is very often because of renal disease. Okay? Metabolic acidosis or alkalosis is often because of some kind of renal failure, renal disease. Okay? Okay, so that's a very common cause. Other causes of metabolic acidosis and alkalosis include ketoacidosis, right? We just talked about someone who's insulin deficient, they have type 1 diabetic, and they're breaking down fat and becoming ketoacidotic. This term, uremia is a condition that happens with renal failure where you have a buildup of nitrogenous waste, including uric acid. Okay. And then sometimes people ingest lots of non-carbonic acid for one reason or another. Okay? The ingestion of lots of non-carbonic acid can cause a metabolic acidosis. Another reason why people get into metabolic acidosis is because of too much bicarbonate loss. And that happens with excessive diarrhea. That can also happen with renal failure, right? The kidneys are responsible for reabsorbing bicarbonate. So when they fail, renal failure can cause acidosis or alkalosis. There's actually a condition called proximal tubule acidosis, which is actually an alkalotic state. But the reason why it's called acidosis is because it will cause, no, it causes acidosis. Why is that there? Oh, because it's metabolic acidosis. Excuse me. Proximal tubular acidosis is actually an impaired ability to secrete potassium, to secrete hydrogen ions. Proximal tubular acidosis is actually an impaired ability to secrete hydrogen ions. Okay? And hydrogen ion secretion occurs at the proximal tubule. And so if you're not secreting hydrogen ions, you get urine that's very alkalotic, but blood that becomes acidic. So that's a cause of metabolic acidosis. Okay. But any acidotic state that is not caused by the respiratory system is considered metabolic. Any acidotic state not caused by the respiratory system is called metabolic. Okay? And so metabolic acidosis is going to be compensated for by the respiratory system. Okay? As is metabolic alkalosis, also going to be compensated for by the respiratory system. So metabolic alkalosis can be caused by excess loss of non-carbonic acids, which includes prolonged vomiting, okay? GI suctioning, right? Suctioning of stomach contents. You get this accelerated loss of hydrochloric acid, whether you're vomiting it up or it's getting suctioned, and that causes an alkalosis. Hyperaldosteronism, because of aldosterone's effect on the kidneys and its tendency to promote both the loss of potassium and also the loss of hydrogen ions. And then sometimes diuretic therapy can also cause alkalosis for the same reason. It interferes with renal conservation of acid and reabsorption of bicarbonate. Okay? Or excess bicarbonate intake can also cause a metabolic alkalosis. So again, metabolic alkalosis, any alkalotic state not caused by the respiratory system is metabolic. Okay? So when trying to evaluate abnormalities in acid-base balance, okay, there's a couple things you have to ask yourself. The very first thing you have to ask yourself is, who's causing the imbalance? Okay? And I had a nursing instructor that used to call this the "who's your daddy" first step. All right? You got to decide who is causing the problem first before you can interpret anything. Okay? So is this, what that means is this a respiratory acidosis or alkalosis, or is it a metabolic acidosis and alkalosis? All right? And then you can decide whether there is compensation and who's compensating. Okay? So let's look at some examples of what you might see with these different alterations in pH. And we have here blood values for pH, PCO2, and bicarbonate during the primary disturbance, as soon as the change happens, and then in the compensated state. Okay? Primary disturbance versus the compensated state. Now, first of all, we're looking at metabolic acidosis. Okay? Metabolic acidosis. You're acidotic, so pH is naturally going to be low. Everybody agree? Is there any reason why your PCO2 would be abnormal in the primary disturbance? No, because the PCO2 is determined by what system? The respiratory system, and the respiratory system is not the problem. Okay? Bicarbonate is low. The bicarbonate system is going to be determined, so bicarbonate levels are actually determined by two different things. Okay? Bicarbonate levels kind of get pushed and pulled depending on what's going on. The higher your PCO2, the higher your bicarbonate levels tend to be. Make sense? The higher your PCO2, bicarbonate tends to increase. The lower your pH, the more acidotic your pH, the lower your bicarbonate tends to be. Why is that? Why would an acidic pH make your bicarbonate levels go down initially? It's being used as a buffer, right? The more acid you have, the more bicarbonate is trying to absorb it, right? And it's being used as a buffer. Okay? So those two things push and pull bicarbonate in different directions. PCO2 levels tend to have a positive effect on bicarbonate levels, and acidity or low pH tends to have a negative effect on bicarbonate levels. So here in the primary disturbance, we have an acidic pH, we have a normal PCO2, and we have a low bicarbonate. All right? So immediately in this primary disturbance, it's clear that the acidity is due to this low HCO3. Right? It's clear that the acidity is due to this low HCO3 because it can't be respiratory if PCO2 levels are normal. Okay? It cannot be respiratory if PCO2 levels are normal. That makes sense? No, it doesn't. A good way of doing this, especially when you start looking at the partially compensated states, is to actually first look at pH. Okay? First look at pH and decide, is it acidotic or is it alkalotic? Okay, so that's step one. Write that down. Is pH acidotic or alkalotic? Step two, look at PCO2. And is the change in PCO2 promoting acidosis or promoting alkalosis or not promoting anything? Okay, so step two, look at the PCO2. Is the change in PCO2 promoting acidosis, promoting alkalosis, or not promoting anything? Now look at the bicarbonate. Is the change in bicarbonate promoting acidosis, promoting alkalosis, or not promoting anything? Okay? So let's evaluate this again. pH, is it acidic or basic? Acidic. PCO2, is it promoting acidosis or alkalosis? Neither. HCO3 being low, is that promoting alkalosis or acidosis? Acidosis. There's your cause. That's all you're left with, right? That's your only possible cause. And so if it's bicarbonate, you know it's metabolic. That's your daddy, metabolic. All right? But you are probably not going to see this person at these levels where the primary disturbance happens. You're much more likely going to see this person at this level where they're partially compensated. And now these steps become even more important. Okay? So let's look at these again and go through the steps. First, this pH, the compensation is, it's not as low as this pH, okay, because the compensation is kicked in, but instead of it being 7.3, maybe it's 7.33. All right? But it's still low. Is that acidotic or alkalotic? Does everybody understand that? So the person's still acidotic. Their PCO2 is low. Would that promote acidosis or alkalosis? Would a low PCO2, I'm not saying that answers that have been yelled at are wrong, but would a low PCO2 promote an acidotic state or an alkalotic state? Alkalotic, okay? So that's promoting alkalosis, a low PCO2. A low HCO3, is that promoting acidosis or alkalosis? Acidosis. So now you have an acidotic pH, you have an alkalotic PCO2 level, right? Or quote unquote alkalotic, that's the direction it's in. And an acidotic HCO3 level, right? So it's pointing in that direction. Okay? So the disturbance that matches the change in pH is what's causing the problem. Make sense? The disturbance that is matching the change in pH is causing the problem. The other value that's in the opposite direction is the compensation. So we would call this, if all I gave you were those values, right? If all I gave you were those values, you should be able to say that is a partially compensated metabolic acidosis. Okay? Let's try another one. Since I don't have chalk, write these values down. That's okay, go ahead.
How do you know it's kind of difficult to tell partially or fully compensated?
Yes.
Based off the fact we're running numbers now? It technically could be fully compensated, right?
What would tell you if something was fully compensated or partially compensated? The pH. The pH value will tell you if it's fully compensated or partially compensated.
Let me just come to the example though.
The example here would mean that the pH would be normal, PCO2 would be low, and bicarbonate would be low. That would reflect a fully compensated metabolic acidosis. Because the levels of PCO2 and bicarbonate are strange, so you know there's something going on, but pH is normal. Okay? So we'll work through a really quick example before I actually need to let you go now. So write down these values. The person's pH is 7.48. Okay, 7.48. And then I'm just going to use high and low for PCO2 and bicarbonate. Their carbon dioxide, their PCO2, their PCO2 is high. Okay? Their PCO2 is high. And their bicarbonate is high. Okay? So let's evaluate this. So pH is 7.4, what did I say? 8. Is that a high pH or a low pH? It's high, which means this person is alkalotic. So we know they're in an alkalosis. Their PCO2 is high. Okay? PCO2 is high. Is that promoting acidosis or alkalosis? acidosis. Okay? So that change is promoting acidosis. Their bicarbonate levels are high. Is that promoting alkalosis or acidosis? Okay. What kind of alkalosis is this? Who's causing it? It's metabolic, right? Because the disturbance is alkalotic, and that matches elevated bicarbonate. So that's the cause. Is this uncompensated, partially, or fully? Partially compensated, because CO2 is elevated. Okay? And so what would this person look like? What would their respiratory rate look like? How do you elevate your CO2? They won't be breathing very well, right? So their breathing will be, the respiratory rate might be low, or at least their tidal volume might be low. So they're under breathing in order to try to compensate for this alkalotic state, but it's only partially compensated because the pH is abnormal. Okay? So I'll give you some examples to play around with. I'll send out some examples, but work on that, yeah.